Hello everyone, this is Dr. Madhusudan Rao. On the program, I teach medical students. Today I am going to talk about an important topic, that is motor system. Well, look into the picture. This is the cerebral hemisphere showing the frontal lobe, parietal lobe, occipital lobe, temporal lobe, and continue downwards in the pons, medulla, and the cerebellum. Look into the prefrontal cortex. Look into the area 6, that is premotor area, and area 4, that is motor area. Our body is represented universally in the motor area, area 4. And the body receives the signals to execute the motor function from prefrontal cortex, the area responsible for the planning of the motor act. And this constitutes the motor system. What constitutes the motor system? Upper motor neuron system and the lower motor neuron system. Upper motor neuron system includes nerve cells, its axons, from the cortex to the lower centers, forming the corticobulbar tracts and the pyramidal tracts. Lower motor neuron system is nothing but the peripheral nerves from the cell bodies and the anterior horn cells on the spinal cord, lateral horn cells, ultimately ending in the neuromuscular junction to bring about the voluntary contraction of the muscles. Then look at these tracks, that is long tracks from the cortex down to the lower centers. They are nothing but the pyramidal and the extrapyramidal tracks, which we are going to touch in course of time. Then before you know the different tracks and the organization of the motor system, how you are going to examine the motor system? You look for the bulk, you examine the power, you examine the tone, coordination, abnormal movements, reflexes, and the gait. How do you assess the bulk? There are two methods. One is by inspection and by measurement. Okay. So what are the parts of the body you inspect for the bulk? Look at the thenar eminence, hypothenar eminence, and the shoulder contour. They will be less prominent when there is bulk is reduced. Measurement. You do the measurement of the arm, take the measurement of the forearm, look at the thigh and mid-thigh measurement, and look at the legs. These are the areas by measurement you can assess the bulk of the muscle. Then in lower motor neuron injury, there is severe loss of bulk and wasting of the muscle disproportionate to the disuse. Okay, it may begin at least a week after the injury. Then what is power? This is power is the resistance against active movement. When you ask the patient to move with limb against resistance, it will give you the strength of that particular muscle. So graded between 0 to 5. Define power. Power is the resistance against active movement. Okay. Grade 0 is no evidence of contraction at all. Flicker of contraction is grade 1. Okay. Movement with the gravity eliminated is grade 2. Movement against gravity but without any force, less than normal force is grade 4 and normal force is grade 5. Okay, and there are ranges between 3 to 5, but you can add plus 1 plus if the power is beyond 5. Okay, because if there is a robust person with the muscular body and the person who is assessing the power is thin, and so in such occasions it is difficult to assess the power of the muscle, and it is varies with the build of the individual, right? With you can add 1 plus to expand the grade beyond 5. Okay, then that's how the power is tested, by the resistance to active movement around a joint. Then pronator drift and pronator drift in the upper limbs. This also helps to assess the power. That what it is, we will tell you. And it helps you to differentiate, is it the weakness is functional or organic. But most of the time when you are assessing the power, use functional tasks rather than manual testing of the individual. Okay, use the functional tasks, like ask the patient to walk on toes, sometimes on heel, or ask him to hop, walk up the stairs, sometimes walk up from the chair without using hands. Okay, standing up the chair without using hands. So that way, if you ask the patient to walk on the tip toes or the heels, so that will give you the power of the muscles you are examining. And also determine whether it is neurogenic or non-neurogenic by pronator drift. Ultimately, they assess whether the UML lesion or LML lesion. Okay, this is the purpose of assessing the power. In UML lesions, power is not that much diminished when compared to the lower motor neuron lesions. Pronator drift. This particular test is going to differentiate between the organic or functional disorder. Keep the hands extended horizontally in front and keep the palms directed upwards. Hands drift down and turn inwards. That is pronation. This occurs in organic paralysis. Okay? Whereas in functional disorders, hands drift down, but palm is remaining unturned without pronation. That is in functional disorders. Erratic drift indicates proprioceptive dysfunction. Okay? Then what is collapsing weakness? Initial good contraction against resistance followed by collapse. You are offering good resistance against the resistance, contracting good power against resistance, but suddenly given away. This occurs in non-neurogenic disorders, usually painful conditions of the joint. Initially, you offer more resistance and there is active movement is good, followed by collapse. This occurs in painful conditions of the joint. Then coming to the EMN and LMN weaknesses. Weakness of upper motor neuron lesion. What are the features? Associated with wasting. This wasting is proportionate to disuse in upper motor neuron lesion. Associated with hypertonia, that means weakness associated with hypertonia and hyperreflexia and other localizing signs, depending upon the anatomic level of the lesion. There could be, for example, if the lesion in the brainstem, there could be concurrent associated findings of the cranial nerve palsies. Like that, in upper motor neuron lesion, wasting is proportional to disuse, hypertonia, and hyperreflexia, and the collaborative findings of the involvement of the other structures. Weakness of the element, how to differentiate, what are the features associated with wasting appears within a week. Okay, it is disproportionate to disuse. The weakness is severe. Hypotonia, that is reduced tone. Diminished intensity of deep and non-reflexes. There is hyperreflexia in humanization. It is the reflexes are diminished in lower motor neuron lesion. Then other localizing signs depending upon the site of the lesion in the LML lesions also. Coming to the tone, what is tone? What is tone? How do you test? The resistance against passive movement around a joint. This can be tested by looking at the posture, altered arm swing, and altered consistency of the muscle, altered resistance to passive movement. These are the four parameters by which you can assess the tone. By looking, by feeling, okay, by moving. That's how you can test the tone of the muscles. Abdominal posture, by looking at, you can say the patient is having hypertonia, say decerebrate rigidity, decortical rigidity. That is abnormal posture is because of the hypertonicity of that group of muscles. Altered arm swing. The muscles are hypertonic, the arm swing will be diminished. Degree of swing is diminished. Altered consistency. This can be tested by feeling the muscles in the first interosseous space, in between the thumb and the index finger. The muscle consistency can be compared with the consistency of the first interosseous muscles. Altered resistance to passive movement. If it is increased, it could be due to spasticity or rigidity. What is spasticity? There is graded increase in the resistance following rapidity of the movements around the joint. That is, this is velocity dependent resistance against the passive movement, and the resistance is suddenly decreased and given away. Okay, this is the clasp knife phenomena. This is a sign of pyramidal lesion. That is spasticity. That is velocity dependent hypertonicity. Velocity dependent increasing resistance to the passive movement and suddenly given away. That is clasp knife phenomena. Then rigidity is the uniform resistance around a joint for passive movement. The uniform uninterrupted resistance to passive movement. This is called lead pipe. If it is interrupted, it is cogwheel, a sign of extrapyramidal lesions. What is paratonia? After initiation of the contraction of the muscle, failure to relax. This is associated with dementia. Myotonia. Failure to relax after contraction. This is disease of the muscles. Then coming to coordination. Tested by asking the patient to perform sequence of movements, not one single movement. You ask the patient to perform sequence of movements. But strength in the limb must be tested prior to testing for coordination. How do you test in the upper limbs? Finger nose test, tapping the thumb and index finger, clapping, tapping on the palm of other hand with the palm, tapping on palm of other hand with the palm and dorsum of the testing hand. Use tap on the palm of the examiner with palm and dorsum of your patient. Then in the lower limbs, go for the knee heel test. Tap in the examiner's hand with the foot. Don't do that. Drawing a number nail with the lower limbs. You just ask the patient to walk. If he can walk, there is no need to test for coordination. Ask the patient to stand on each leg for 10 seconds without support. This is sufficient to test for coordination. Okay. What is the clinical significance? It is disturbed in cerebellar functions. Besides, there will be dysmetria, dysdiadochokinesis, and tremor. Dysmetria is the patient is throwing his hand behind the object. Okay, that is dysmetria. Dysdiadochokinesis, failure to perform the supination and pronation alternately. He is unable to do that. Tremor is this is intentional tremor that you get in the cerebellar functions. Tremorous stress is the feature of extrapyramidalization. That is Parkinsonism. Then look for muscle strength. Will be diminished in cerebellar lesions. Look for muscle stiffness and hypokinesia in cerebellar lesions and test for the comprehension. Abnormal movements. These are tremor, chorea, ethetosis, hemibalismus, dystonia, and fasciculations. Tremor is most common type of involuntary movement. Then it could be symmetrical or asymmetry. Look for its frequency and the circumstances where it is occurring. These are the points under which you have to test for tremor. Is it symmetrical or asymmetrical? The frequency, rapid or more, that is more than 7 cycles per second, or slow, less than 7 cycles per second. Is it occurring at rest or on movement? Tremor at rest is diagnosis of Parkinsonism. Then tremor on movement, action tremor is cerebellar lesion. Type, is it physiological? Physiological is rapid. Parkinson's, slow and asymmetrical, associated with hypokinesia and rigidity. Cerebellar, it is intentional tremor with hypotonia. Senile tremor is an old age tremor, it is not that symmetrical. Yes. Fine tremor. Look for fasciculations. This is the second most common one. Involves one more motor unit. Okay. Seen or felt. Damage to the lower motor neuron results in fasciculations. Damage to the muscle. Benign, sometimes seen in calf muscles. Okay. Look for others. Involuntary movements like chorea, which is rapid, non-stereotyped, jerky movements with emotional instability. Okay, more common in children with rheumatic fever. Ethetosis, slow writhing snake-like movement involving the extremities. Chorea is more common in the proximal muscles. Ethetosis is more commonly seen in the distal muscles. Dystonia is nothing but a sustained twisting of the trunk or neck. Hemiparosmus, flinging of one half of the body may result in fall. Yeah. Tics, stereotyped, fine, repeated movements. Decide whether the relation in the cerebellar, basal ganglia is metabolic or genetic or associated with cerebrovascular accidents. By looking for the associated findings, you can localize the lesion. Station. It is ability to stand with feet relatively close by, with eyes open or closed. That is the stance or station. Observe the patient for swaying to one side or both sides or fall. If the patient is able to stand with eyes open but sways when the eyes closed, it is called rhombogism. It is said to be Rambach's positive. That is, the patient is able to stand with eyes open but sways when the eyes closed. It is positive Rambach's. Diagnostic of posterior column dysfunction. Okay. Sways with eyes open or closed, indicative of cerebellar or vestibular dysfunction. Okay. Because there are three important tracks that are going to maintain your balance. That is vestibulospinal, spinocerebellar, and the posterior columns. Okay, the eyes are going to compensate for rest of the tracks, functions of the rest of the tracks. Eyes are going to compensate for the cerebellar and vestibular dysfunction. So, when the eyes are open, patient is able to stand erect. When the eyes are closed, he sways. Right? But to some extent, he can maintain the balance even in the cerebellar and vestibular dysfunction. But he easily falls once there is eyes are closed. Right? But by and large, what is described is the rhombogism is positive in the posterior column dysfunction. Okay, patient is able to stand erect with the eyes open, but he sways when the eyes are closed. This is the lesion in the posterior column and a positive rhombox. Whereas in cerebellar and the vestibular dysfunction, patient's face with eyes open or closed. Okay, you remember this much. That's enough. Swaying to one side in vestibular lesion, swaying to both sides in midline cerebellar dysfunction, that is furunculonodular lobe dysfunction. Then go to the deep tendon reflexes to decide whether the weakness is due to UMN or LMN. DTR is diminished in LMN lesion, hyperactive in UMN lesion. What are the deep tendon reflexes you test? Biceps, triceps, supinator, knee, ankle. Okay? And assess the colonus, ankle or calcaneus. Deep tendon reflexes are monosynaptic, that is, center is in the spinal cord, whereas superficial reflexes are multisynaptic because their centers are far above the cortex, in the sensory area of the cerebral cortex. Superficial reflexes, what you test is abdominal, cremaster, and plantar. Where abdominal reflexes, you test the upper abdomen, lower abdomen. Upper abdominal superficial reflexes are absent in the upper motor neurons like pyramidal lesions, plantar will be extensor. Well, coming to the disorders of motor system, it may include upper motor neuron lesion, lower motor neuron lesion. A lesion could be at the neuromuscular junction or in the muscle. Upper motor neuron dysfunction. So the lesion could be in the corticospinal tracts. Okay. What are the features? It could be pyramidal or extrapyramidal. What are the features of the upper motor neuron dysfunction? If it is acute phase, in acute phase, what do you find? There is weakness of the contralateral half of the body. Okay. Distal muscles are maximally affected, followed by the proximal trunk, proximal muscles. Diminished tone. In acute phase, there is hypotonia and absent reflexes. Over a period of 1 to 3 days, that is within 48 hours, you can say, tone becomes normal or sometimes increased, that is spasticity. Reflexes become exaggerated. Superficial reflexes like abdominal cremaster are absent and Babinski extensor. Over a period of few weeks to months, you can expect weakness being improved in the proximal muscles. Okay, but recovery in distal muscles is poor. It may take a long time to recover. But ultimately, the recovery of power in the distal muscles is poor. Look at the motor system. So, how many centers are involved? Say from the cerebral cortex down to the thalamus, then pons, and coordinated by basal ganglion function, cerebellum, brainstem, then down to the spinal cord in the form of lateral motor system and the medial motor system. It is the complex circuits between the higher and lower centers, that is organized function of these structures in order to carry out the smooth voluntary motor act. Okay. There are direct and indirect pathways of the corticospinal fibers or the pyramidal tracts. The direct pathway, it is isolated pyramidal tract. Direct pathway is, it is isolated pyramidal tract. Corticospinal tract, it is purely pyramidal tract. This starts from the motor cortex, then pyramidal fibers, isolated damage to the medullary pyramids. So, when do you get the direct pathway injury? If it is isolated pyramidal tract. Okay, that results in the injury to the direct pathway. The pathway starts from the cerebral cortex through the pyramids in the medulla. The injury is isolated damage to the pyramids in the medulla. That results in distal muscle weakness, but no spasticity, no hyperactive reflexes. Okay, if there is damage to isolated pyramidal tracts, there is no spasticity, no hyperreflexia, but there is involvement of the distal muscle weakness. Okay, what is indirect pathway? It includes pathways involving basal ganglia, cerebellum, along with the pyramidal fibers. You remember this point. It could be at the premotor cortex or corona radiata or internal capsule, brainstem, that is cerebral peduncles, basal pons, and lateral corticospinal tract. This results in weakness with increased tone and hyperreflexia. Okay? Again, extent of lesion and mode of onset determines the duration of spinal shock and degree of spasticity. Okay? If the lesion is small, duration of the spinal shock is less. And degree of spasticity is also not that remarkable. Understood? So, pyramidal and main descending tracts, that is motor tracts, could be direct pathway or indirect pathway. Okay. Isolated pyramidal tract injury at the medullary pyramids is associated with the injury to the direct pathway. Indirect pathway includes basal ganglia, cerebellum, along with the pyramidal fibers. Okay, that is the indirect pathway. If that is involved, either in the premotor cortex, corona radiata, internal capsule, or the brainstem, results in hypertonia and the hyperreflexia. Okay, remember this point. Isolated injury in the medullary pyramids results in distal muscle weakness without spasticity, without hyperreflexia, though it is injury to the upper motor neurons. Okay. What is the direct pyramidal system? This is the cerebrum, midbrain, medulla oblongata, the anterior horn cells, the anterior corticospinal tract, and lateral spinal tract. But there is no involvement of the other tracts like involvement of the basal ganglia. Okay. As I told you in the previous slide, without involvement of the other pathways, basal ganglia or cerebellum is the direct pyramidal pathway or direct system. Pure pyramidal system, you can say. See the fibers and then the cerebral cortex running downwards through the midbrain. Okay. Then at the pyramids, they are entering the pyramid. The acquisition occurs, few directly running downwards. Nearly 80% of these fibers they cross to the opposite side to run in the lateral corticospinal tract, and a few run directly into the ventral corticospinal tract. What are the functions of these two? Lateral corticospinal tract maintains the paraxial muscles. Okay, that is the muscles of the limbs. Whereas anterior spinal tract, corticospinal tract is responsible for to maintain the balance. That is axial muscles. Indirect is the extrapyramids, pyramidal pathway. Look at the organization of the motor system. See, descending system, upper motor nerves, that is motor cortex, including basal ganglion and cerebellum. They run downwards, resulting in the control on the skeletal muscles. This is the organization of the motor system. That is, higher centers at the motor cortex, they are combined with the fibers coming in the basal ganglia and the cerebellum, ultimately become the bundle of fibers that controls the lower centers in the spinal cord. and the ultimately skeletal muscle. This is again looking into the organization of the motor system. What is extrapyramidal motor tracts? This includes motor pathways not part of the pyramidal system. Okay, not part of the pyramidal system. Remember that. Those in part of the pyramidal system forms the indirect corticospinal tracts, whereas pyramidal system purely, that is extrapyramidal system purely, is that one not includes the pyramidal system. Upper motor nerves originate in the nuclei deep in the cerebrum, not in cerebral cortex. Okay, that is there in the basal ganglia. They do not pass through the pyramid. Remember this one. Extrapyramidal motor tracts, they do not pass through the pyramids. Okay. Well, LMN is on Andrehorn motor neurons. This system includes rubrospinal, vestibulospinal, reticulospinal, and tectospinal. Okay, rubrospinal from the red nucleus down to the spinal cord, vestibulospinal from the vestibular nuclear apparatus to the spinal cord, from the reticular formation in the pons down to the spinal cord is the reticulospinal, tectal nucleus to the tectospinal tract. Okay, it regulates axial muscles to control the posture. Okay, muscles responsible for the coordinated action, coordination, head, neck, and eye movements. Okay, the functions of these extrapyramidal tracts. Out of all these four tracts, vestibulospinal does not cross to the opposite side. Features of the extrapyramidal lesion. This is difficulty to initiate voluntary movement. There is hypertonia, rigidity is the feature of extrapyramidal lesion. No loss of power of the muscles. There is bradykinesia, involuntary movements, and postural instability. What are the points to remember? Number one is try to remember what is spinal shock. Longer duration, days to week. That is, duration depends upon the acuity of injury. If the injury is acute, it takes longer time. Large area damage, the spinal shock is of long duration. Injury of gradual onset, usually not associated with spinal shock. If there is acute injury, if the area of injury is large, then it's longer is the duration of spinal shock. It is a result of excessive inhibition of lower centers. Okay, that is responsible for spinal shock. Because naturally higher centers will have the inhibitory role over the lower centers. Otherwise, the lower centers, they work according to their will. So always lower centers are kept under control by the higher centers. This is the release phenomena which manifests as hypertonia and hyperreflexia in upper motor neuron lesions. Then coming to the spasticity. Degree of spasticity and exaggerated reflexes depend on the extent of the lesion and the number of neurons damaged. Okay. Lesions of cerebral hemispheres and brainstem usually results in some sensory disturbance. Look into that particular point. Whereas if it is pure UMN lesion without sensory disturbance occurs in small vascular lesions. of posterior limb of the internal capsule and basal pons. Okay. Coming to the basal ganglion disease, characterized by hypokinesia, okay, slow onset of action, difficult to correct posture, soft speech, and dysphagia. And the patient will be having difficulty in swallowing. Hyperkinesia, that is chorea, acidosis, hemibilismus, and dystonia, are the features of basal ganglion disease. If it involves like corpus striatum, whereas Parkinson's is because of the involvement of substantia nigra. There will be rigidity and reflex system normal. Coming to a note on the extrapyramidal tracts. These are all descending tracts. They originate at a cerebral cortex, mainly area 6, 8, 1, 2, area 3, and also area 5. But connections with other subcortical centers. Okay, but these should have the connection with the subcortical centers like basal ganglia, reticular formation, vestibular nuclei, and red nuclei, and the alveolar nuclei. The central, the origin, if it is in the cerebral cortex, they should have the connection to the lower centers. As said, basal ganglia, reticular formation, vestibular nuclei, red nuclei, and alveolar nuclei. What are the extrapyramidal tracts, which I already mentioned? Rubrospinal, tectospinal, reticulospinal, and vestibulospinal tracts, and oliospinal tract. This, remember the nucleus from there where it is starting, and end with the spinal center that forms the respective tracts. These are the extrapyramidal tracts. They are considered as series of tracts. Rubrospinal, reticulospinal, which has got medial and lateral, tectospinal, and vestibulospinal tracts. Look at this is the arborization of the motor system, involvement of the cortex, thalamus, brainstem, spinal cord, and reconnected with the cerebellum, which again projects its fibers into thalamus and the higher centers. This I have already told you. Then there are specialized areas, motor areas in the brain, like Broca's area, the center for the voluntary movements, center for the head rotation, etc., area for the hand skills. These are all located in the premotor area, okay, because they bring about the motor functions. So general organization of the motor system. This picture again shows the complexity of the motor circuits. Cerebral cortex contains the numerous circuits to perform the motor control act. Okay, we are carrying out the motor act so smoothly, well coordinated. It's not brought out by simply by the centers in the cerebral cortex. It is brought out by the complex circuits involving the subcortical centers, cerebellum, and the other centers in the brainstem, like the red nucleus, that is vestibular nucleus, olivary nucleus, etc. And the thalamus, that is you have got the corpus striatum, which includes basal ganglion. So cerebellum and the basal ganglia also participate in the important feedbacks, which form the loops, which in turn give the feedback to the cerebral cortex by internal ascending fibers from the lower centers to the cortex. There is descending fibers, feedback with feedback looping system, which project in turn to the cerebral cortex, via the thalamus. Sensory inputs also play an essential role in motor circuits and feedback loops. Okay, so this is the complexity of the organization of the motor system in order to bring about a smooth, well organized motor act. Okay. To conclude, recall the what is pyramidal tracts and the extrapyramidal tracts. Pyramidal tracts are lateral corticospinal and ventral corticospinal and corticobulbar. Corticobulbar innervates the motor nuclei of the motor cranial nerves supplying the face. Then coming to the lateral corticospinal is responsible for the fine movements, whereas ventral corticospinal tract is responsible for postural movements. Then the centers, higher centers for the pyramidal tract are located in the precentral gyrus, that is motor cortex, descend directly from the cerebral cortex to the spinal cord. Okay, there is no stopover in the over the motor nuclei of the cranial nerves. 80% cross in the medulla, 20% cross in the spinal cord. Ultimately form the lateral and the ventral corticospinal tracts. Lateral cerebral cortex is responsible for the fine movements, and that is needlework, writing, etc. Ventral is responsible for the postural movements. Coming to the extrapyramidal tracts, we have rubrospinal, vestibulospinal, reticulospinal, and tectospinal. They originate in the brainstem nuclei. No direct control of motor cortex. Three out of the four they cross except the vestibulospinal. What are their function? Control body posture, involuntary movements. Okay, results in the disorders, features which I described already. This is again the pictorial diagram showing the motor pathways. You see the cerebral cortex, corona radiata, thalamus, then you have got the caudate nucleus here, then there is internal capsule, the fibers running down into the midbrain, giving away the corticobulbar fibers to the motor nuclei of third and fourth cranial nerves, then descending down into the pons, and the fibers giving away the corticobulbar fibers to the motor nuclei of the fifth, sixth, and seventh nerves, cranial nerves, then ultimately descending down to the medulla. At the lower part of the medulla, they cross to the opposite side in decreasation. In medulla, again they give away the fibers to innervate the motor nuclei of the ninth, 11th, and 12th cranial nerves. Okay, ultimately descend to the spinal cord in the form of anterior corticospinal tracts and the lateral corticospinal tracts. This is again a pictorial representation of pyramidal system. You have got the direct pathway, you have got direct pathway. The axons of one neuron travels from the cerebral cortex to the lower motor neuron, such as the alpha motor neurons. They have again two pathways, lateral corticospinal tract and ventral spinal tract, corticospinal tract, which I already mentioned, but look into this picture. This is the pure pyramidal pathway. So going into the pyramids in the medulla, down below here, medulla, then decusating most of the fibers and few fibers running directly to form the ventral corticospinal tract. Okay, from there start the lower motor neurons to innervate the skeletal muscles. Okay, this is the upper motor neuron till the spinal cord. From the spinal cord to the skeletal muscle is the lower motor neuron. Look at this picture, it's very important for you students to remember. Red lines are the efferent pathways, blue lines are the afferent pathway. Okay, blue area reflects the afferent sensory pathways and red lines reflects the efferent motor pathway, which includes pyramidal, lateral and anterior, extrapyramidal, including the rubrospinal, reticulospinal, olivospinal, vestibulospinal, etc. Okay, these are the ascending sensory pathways and the descending motor pathway. In ascending pathways, you see the posterior columns, okay, spinal cerebellar tracts, okay, all the tracts they take the impulses from periphery to the center and they give the signals, stimulate the higher centers. In turn, the response is executed by the impulses traveling the efferent motor pathways. That's how you carry out your motor act so smoothly in order to carry out the routine. To conclude, to recall this picture shows the origin of the corticospinal pathways from the cortex at the higher centers, running through the internal capsule, then passing the brainstem at the lower border of the medulla. The decussation of the most of the fibers to the opposite side to form the lateral corticospinal tract, and there is anterior corticospinal fibers who cross at the lower center. Okay, ultimately innervate the motor nerves in the spinal cord. Coming to the cerebellar diseases, characterized by the cerebellar hemisphere is responsible to control the movement of the extremities. Okay, hemispheres control the movements of the extremities. Okay, the smooth movement of the extremities brought out by the cerebellar hemispheres. The lesion results in tremor, hypotonia, and ataxia. You see, if the functionality of the cerebellum is lost, even though command comes from the higher centers, is carried down by the corticospinal fibers. There is no control of the functions of the cerebellum. There is no perfection in the voluntary act. It is broken down into tremors, ataxia. Okay. Then vermis controls the axial muscles. The lesion in the vermis results in the truncal ataxia. You see, if the patient is asked to stand erect, sit erect, he cannot sit erect, he falls down. Then there will be dysarthria and abnormal eye movements. That is nystagmus, cerebellar nystagmus. If there is nodular lobe is affected, there are disturbance in the eye movements and severe nystagmus. Okay, these are the features of the cerebellar disease. Besides, dysdiadochokinesis, dysmetria, which I told you already. Lower motor neuron lesion includes the lesion from the anterior horn cells down to the neuromuscular junction. It presents with weakness, hypotonia, hyporeflexia, and wasting which starts within days, which is disproportionate to the degree of disuse. This is associated with the sensory disturbances because the spinal nerve is a mixed nerve. These are the features of lower motor neuron lesions. Okay, with this, I conclude today's talk on the motor system. Thank you very much for patient listening. My dear students, remember this particular topic very carefully and watch my video, and best of luck all the time. Thank you very much. See you next time in the next class. Until that time, this is Dr. Madhusudan. Bye bye.